long COVID, as defined by the WHO, is any persistent symptoms after SARS-CoV-2 infection that occur within 3 months and last more than 8 weeks. It's slightly different definition by NICE, so you have to have persistent symptoms for 12 weeks. But when we're looking at long COVID, we know that there's up to 250 recognised symptoms, which makes it a very difficult condition to manage if we're only looking at symptomatology. And to really understand this disease, we need to be looking at what the cause of the symptoms, and that's called pathophysiology, and that's the medical term for the disease process that's going on in our bodies that is causing all the problems and all the symptoms that these patients are getting. And so what we now believe long COVID actually is, it's a virally triggered, immune-mediated, multi-systemic inflammatory condition that can affect almost every bodily organ system, but also has roots in the blood vessels as well. And we're beginning to realise now, we've now got 404,000 publications worldwide on this condition, so it's been studied quite extensively, that actually there are certain symptom clusters we see in certain groups, and we are now aware that there are various different pathophysiological or host response pathways being triggered by the virus that may be causing certain symptom groups. So long COVID is more an umbrella term for lots of different things that could be going on. Now, you can have in some individuals all of these different pathways happening at the same time. In other individuals, it'll be more one thing, more vascular, for example. In a different individual, it'll be more immune-mediated symptoms. So we can kind of narrow it down to different phenotypes or subgroups now, and that's where some of this work is now focusing on. One of the things that we've seen clinically is there are certain groups that seem to have immune-mediated issues, and we've seen lots of innate immune dysfunction initially, maybe an overreactive immune response, production of cytokines, issues with mast cells and histamine, and this subgroup do seem to respond to antihistamines. There is another group which develops something called post-COVID dysautonomia, and we have published research from a colleague of mine in Australia showing that up to 79% of people can get dysautonomia. Now, what that actually means is dysautonomia is abnormalities of our autonomic nervous system. So those are the nerves that control our unconscious bodily functions, like our heart rate control, our temperature regulation, our blood pressure regulation. And the most common one we see is a condition called POTS, postural orthostatic tachycardia syndrome, and IST, which is inappropriate sinus tachycardia. And that is a subgroup that we can treat, and can show you what happens here, and it can be very disabling for patients. So if you imagine this is your head, and this is your blood, and this is your body, and when you lie down, that blood's getting to your brain. Now, when you stand up, what should happen, or what would happen if you didn't have pressure receptors, is when you stand up, due to the effects of gravity, a lot of that blood is then dumped into your splanchnic circulation in your lower limbs, but you don't want it to reduce the blood flow to your brain because you're going to get dizzy and lightheaded and not feel very well. So you have these pressure receptors and other receptors adjacent to the blood vessels, and you have an autonomic nerve called the vagus nerve that takes signals up to the brain, tells them that you've moved, and sends signals back down. And so what should happen when you stand up, in effect, you get this signal from your vagus, and it tells your blood vessels to squeeze, and the blood goes right up to the brain, and so you don't collapse. Now, what happens in long COVID when you've got dysautonomia, that mechanism, that safety mechanism, is lost. And we don't fully understand all of it, but we know that SARS-CoV-2 is infecting the inner lining of the blood vessels. And they're not just tubes that deliver oxygen, they're living, breathing organs. So if you send that message back and the inner lining of the blood vessels are inflamed and can't produce the molecules telling the blood to squeeze, it doesn't do it. But in addition to that, we now have published research showing that the virus itself can infect and inflame the vagus nerve that's regulating this system. And so we have two potential mechanisms for what happens. And when that happens, you then don't get enough blood flow back to your brain, but you don't get enough blood flow back to the right side of your heart. That means the amount of blood being pumped out the left side of your heart drops, and your heart and your blood vessels and your nerves try to compensate by getting something called sympathetic overdrive. So your heart starts racing to try and maintain that oxygen flow to the brain. When it starts racing, the main pumping chamber of the heart has a less time to fill. And so every time the heart beats, there's not as much blood in it to push out, so it self-perpetuates. And so you end up with these racing heart rates when you stand up, and to the point some people actually faint or pass out or feel really unwell. And we're seeing that quite a lot. So that's one of the phenotypes, and we do have treatments for that. So it is really important that we break this down, because some of it we can treat. Another group that we are seeing is what I like to call the vascular coagulation phenotype. With long COVID, again, when the virus infects and gets into the bloodstream, it can infect and inflame the inner lining of the blood vessels, the endothelium. It can disrupt the endothelial glycocalyx, which is kind of a protective layer. And it also has knock-on effects with molecules in your bloodstream called platelets, which are involved in activating blood clotting. So they become hyperactivated, and it triggers the clotting cascade, and then you can make thousands of little fibrin amyloid microclots. If you get big blood clots, there are risks after COVID infection of heart attack, of stroke, of blood clots in the lung. If you get these little fibrin amyloid microclots, we think they may be playing a role in some people, not in everybody, because this is a heterogeneous spectrum, in maybe sludging up the blood flow in the capillary vascular beds, which are the tiny little blood vessels, and causing the capillaries themselves to get inflamed and disrupted, and inflammatory molecules to potentially leak out of the little mini blood vessels into the solid organs. And then, if you're not getting enough oxygen to your brain, you get brain fog. If you don't get enough oxygen to your heart, you get chest pain. If you don't get enough oxygen to your muscles, you get muscular fatigue. And it's about understanding what's causing the symptoms, because if you can treat the cause, you won't just treat one symptom, you'll treat a myriad of symptoms, and the patients start to feel better. A lot of the tests that we're doing, that we have access to in the research field, we don't yet have access to clinically. And one of the big problems is the standard blood test, the standard imaging test that we tend to do to rule out pathology in medicine, often come back normal. It doesn't mean there's nothing wrong with the patient. For example, fibrin amyloid microclotting, you can't see on a normal blood test. You have to have immunofluorescent microscopy, you have to have THT staining, endothelial dysfunction, which is inflammation of the inner lining of the blood vessels. There are lots of markers that can be elevated, blood markers that can be elevated, but they're not yet routinely available in clinical practice. But we are seeing these very, obvious abnormalities in the research setting. So just because we can't do the research tests clinically yet, doesn't mean the patient doesn't have anything wrong with them. But when you've seen enough patients, there are very obvious patterns that are emerging. And there are certain symptoms that are very prevalent. So the big ones are fatigue. And again, there's some published data on this in around 87% of individuals. There's PESI or PEM. Now, PESI stands for post-exertional symptom exacerbation. PEM stands for post-exertional malaise. It's the same thing, it's just different terminology. And that, it's not just tiredness, it's beyond that. It's an abnormality, we think, and we're still learning about this, of oxygen metabolism and aerobic metabolism. And there's been some really lovely work that's come out of the Netherlands with my colleague Rob Vos' group recently, looking at this and doing cardiopulmonary exercise testing at different intervals and doing biopsies of the muscles of patients before and after exercise. So this particular condition is a hallmark of both long COVID and ME/CFS, which is a myalgic encephalomyelitis. Patients become exercise intolerant if they try and push beyond this reduced exercise energy envelope. They might not feel it that day, but the day after or the day after that, they'll be absolutely floored, and it can actually do them real harm and can really set back the recovery. And some of this research showed that there was alterations in the anaerobic thresholds, that there was alterations in muscle fibre morphology, and that they were finding these fibrinolyl deposits actually in the muscles themselves, and that obviously needs to be looked at in a bit more detail. But it does appear that there is some issues with oxygen metabolism and possibly metabolism at a mitochondrial level, and that's the workhouse of our cells. And what the mitochondria are responsible for is producing the energy molecules that allow us to be who we are and to have the energy to do things. And that's called adenosine triphosphate, or ATP. Now, if you don't get enough oxygen into those cells, or your mitochondria are not working properly, you're not going to make enough ATP, and you're going to get cellular fatigue, and you're going to feel awful. You know, this is a real condition, and we're just beginning to scratch the surface of it. Brain fog is actually cognitive dysfunction. So you see a very obvious, once you know what you're looking for, pattern of dysfunction. It's not just, you know, feeling a bit fuzzy or a little bit forgetful. It's the dysexecutive syndrome that we sometimes see, and that's to do with your higher executive functioning. So people have problems with concentrating, they do have some problems with memory, they may be speaking a sentence and then they'll forget a word, or they're writing something down and they'll read it back and they've missed out a word. Some of that could be related to neuroinflammation in the brain. We know that there is neuroinflammation caused by SARS-2, and there's been a very elegant paper published by one of my, by the Polybio group, looking at the vascular inflammation, which is the area I'm interested in, being a cardiovascular specialist, and that there's a direct relationship between vascular inflammation and neuroinflammation in the brain of long COVID. But again, getting it diagnosed in routine clinical practice at the moment is quite difficult, because it does involve specialist scan testing that isn't routinely available for many people. So I think what we need to be focusing on now, we know the abnormalities are there. We've been studying it for 4 or 5 years now. We have got hundreds of thousands of research papers, and we need more investment in the research to allow us to bring some of these tests into clinical practice, and to allow us to start looking at potential treatment trials. So I have been a medical champion for the Long COVID Kids charity for a few years now. My concern has always been, I know at the beginning we were told children don't get affected with COVID, they don't transmit, they don't get sick, and as time has gone on, we've shown that actually one of the highest transmission rates in 2021 was in high school children. We know now that children can get affected by COVID and do get long COVID, and obviously we don't yet know what the long-term implications of all of this is going to be. And my biggest concern is that we have a virus that we know is neurotropic and vasculotropic, meaning it can damage your brains and your blood vessels, and yet our children are getting repeatedly reinfected through school, and we don't know what we know that the acute index infection in kids, generally speaking, is milder than in adults. But it's not the acute index infection that we're concerned about, it's what are the long-term implications, and we just simply don't know what they are yet. But I think there needs to be a lot more research in this field, and obviously it's heartbreaking when you see these kids being really sick. And I've spoken to quite a few of the kids. We're working at the moment with the Long COVID Kids charity on a research project, because we feel that there's not enough work being done in this space with the children. And we have been very lucky that we are in the process, we're just about to start running a research trial specifically looking at the damage that COVID may or may not be doing to our children, and then potential treatments for some of the kids that have been suffering with long COVID for a while now, because they're very debilitated. I mean, we've got these children, it's heartbreaking. Athletes, gymnasts, football stars at the age of 8, 9, 10, 12, and they're now in wheelchairs, and it's just horrific. What we know from the published data so far is that there appears to be, unfortunately, a cumulative increased risk of developing long COVID with repeated reinfections. Now, that doesn't mean that if you have a 10% risk with your first infection, you're going to have a 10% risk with your second and a 10% risk with your third. It doesn't work as simply as that. And partly that's to do with vaccination status, partly that's to do with how, previous exposure, and have you developed any immunity from previous variants. Different variants, are more likely to cause more problems than others. So the cumulative risk doesn't rise in a linear manner, we think, but it does seem to be rising from the research we have available to us, and obviously we're still looking at this and learning. It's not just long COVID that's going up. So we know that COVID seems to be associated with increasing the risk of cardiovascular disease and neurological disease and endocrine disease, including diabetes in children, and autoimmune diseases. And when they looked at this in people that had 1, 2, 3 infections, that risk seemed to go up with infections. So ignoring this because we think the acute index infection has got milder, I think we would do that at our peril, because there's a big concern about both the health burden and the future economic burden of this disease in the chronic phase if we don't get on top of it now. Long COVID is likely to affect our economic growth and put added pressure on the NHS if we don't start to tackle this problem properly. And what they've specifically said is in their economic modelling, given the current long COVID levels, and they're not that accurate because our ONS survey was shut down last year, so we've only got data from last March, they predict that by 2030, long COVID will have reduced UK GDP by 1.5 billion per annum and will be costing 138,000 lost jobs per annum due to long-term sickness from long COVID in the workforce. If long COVID numbers go up from 2 million to 4 million by 2030, then that would be an annual reduction of 2.7 billion in UK GDP, and 311,000 jobs will be lost per annum from the workplace. So that's obviously got a lot of concerns, not only about the long-term health of the nation from long COVID, but also about pushing people into poverty as well. I think we all need to start taking the potential long-term consequences of this illness a bit more seriously. And I think the World Health Organization have given some very clear guidance on this. And I think we need to be following the WHO guidance and the science, the multi-layered Swiss cheese approach to mitigations, reducing transmission, because the best way to stop lots of people getting long COVID is to stop lots of people catching COVID. We absolutely need more funding for research because we have, although it might feel to the long COVID sufferers, we haven't progressed very far because we haven't managed to find a cure. We do have some treatments for certain subgroups of long COVID that are helpful, but we've also got a much better understanding of the mechanisms causing long COVID now than we had 4 years ago. Not just long COVID, but the truckload of other health conditions that can be exacerbated or potentially caused or associated with previous SARS-CoV-2 infection. And what I think we need now is we really need governments, not just our government, but governments everywhere, to invest in this and to plough lots of money into treatment trials, because we have a huge list of potential drug therapies that we think might be helpful for treating long COVID, but we can't roll them out until we've tested them to make sure they're safe and effective. And the other thing to say with long COVID, because it's not just one thing, because it's lots of different pathophysiological pathways involved at once, I don't think there will be a single magic bullet drug. It's going to take combination therapies because we need to be targeting different parts of the pathophysiological pathways. But that also means we have to phenotype patients better, because we need to understand and almost individualise medical care. Some people might have very bad clotting abnormalities and they might benefit from anti-clotting agents, for example. Others might have really bad dysautonomia and they might benefit from the, the fluid salts, beta blockers or rivabradine and the various other drugs we give for that. Others might have issues with inflammation, others might have myocarditis, and the treatment for each of those things is different. So it's a huge undertaking, but the other thing that we really need to be doing is to try and stop more people getting this, because at the moment we don't have a cure. We know COVID is airborne, and so masks, like cloth masks that some people buy, just down their local supermarket, have been shown not to be effective in preventing infections. But respirator masks are good at preventing infections. If you are wanting to protect yourself until such time as we've got really good air filtration in places. Going into an indoor crowded place, the type of mask that would protect you from catching SARS-CoV-2 would be FFP2 or FFP3 masks, which are, that's European standards. The equivalent in the US would be N95s or N99s that are effective in protecting you against airborne pathogens. Air filtration and ventilation. So this is just a CO2 monitor, and it gives us a rough idea of how clean the air is, how many air turnovers there are, so it's kind of a surrogate marker. If it's over 1,000, then you're starting to get into the territory where you're getting a little bit concerned. And again, the World Health Organization have released a very comprehensive document just very recently on this, huge document about air quality and air standards and ventilation and air filtration, and talking about the risk of actually catching SARS-CoV-2 depending on how many air changes per hour, depending on your CO2 levels, depending on the size of the room, how many people are in it. So you can actually work this out now, and if you put air filters like this one here into schools and nurseries, you will reduce COVID outbreaks in schools, you will reduce sickness absence, you'll improve attendance. You know, our kids' education is very important, but so is their health. And at the moment, you know, we have children going to school with symptoms who may have COVID infections into classrooms of 30 and spreading it around. And they might just feel unwell for a week or two, but some of them might be disabled for a long time, and we don't know which child that's going to be. Teaching staff and healthcare workers have some of the highest occupational levels of long COVID that we've seen in occupational work groups. Obviously people would say, well, how much is that going to cost? Can we afford it? I would ask, can we afford not to? One of the things we said at the APPG when we were asked to talk to the politicians was, how should we be tackling long COVID? And actually we had a six-pronged approach. So acknowledge and educate. You have to recognise you've got a problem before you can fix it. Prevent, because prevention is always better than cure. Protect, and we need to start protecting our kids, and we need to start protecting our medically vulnerable in hospitals. So clean air in schools and hospitals, please, that would be wonderful, thank you very much. Research and treatment. Now, probably the most cost efficient way of doing that is to integrate the two, and we actually had a huge discussion about this at an NIHR webinar last year with patient groups and with researchers and with clinicians. That would be a really good way of doing it. And we also talked about whether we should be having, even at an international level, an international task force to say these are the research priorities, rather than each country doing its own thing or each research group doing its own thing. And this is what my colleague Caroline Dalton's idea, and I think it's brilliant, is actually we need to sit down and go, these are the priorities that we think might help for long COVID treatment. Your group's an expert in this, you do that trial, we'll do this trial, you do that trial. But recruit from the COVID clinics, and you can get them and you can monitor them through the COVID clinics as well. But it would take a lot of organising, but it could be done if we had the proper infrastructure and the proper investment. I think it would be very helpful to have the level of investment in long COVID services match the level of need, because for the individual it's incredibly important, but also, again, going by the economic argument, we can't afford not to. There is no rug big enough to sweep long COVID under. If this is going to be costing our economy 1.5 billion per annum, possibly up to 2.7 billion per annum, plus losing lots of people from the workforce. Because the other thing, just to mention, is some people have this slightly false idea that the only people that get long COVID are really, you know, elderly people or multiple comorbidities, but if you're young and fit and healthy, you're not going to get it. Unfortunately, that's not true. There are some groups that are more at risk than others, but actually one of my colleagues in the States, Dr. David Petrino, runs a big long COVID clinic in Mount Sinai in New York, and he's recently audited his long COVID patients, and the mean age of his clinic is 38. So this is our current workforce. This is our current workforce that's being disabled. So as well as at a personal level, it's destroying lives, as well as at a family level, it's destroying lives, as well as at, you know, a kind of a wider health burden to the NHS level. We're also got the economic implications at a country and a nation level of what might happen in the future. And that in itself has then ongoing implications, because the people that are going to be most affected by, you know, a crash in the economy or reduction in GDP or growth or losing their jobs or losing their homes are going to be those that are on that borderline, the socioeconomic groups. And then obviously there's a risk about, is that going to tip certain people, if they get sick, over into poverty? And this is potentially at least partly preventable disease, so we need to start preventing it.